Good afternoon. Hi, I'm Cheryl Chang, and my colleague, Dr. Giuseppe Citario, are here to talk about, is this patient dead? I just wanted to start out, slide please.
How many of you did already seen a brain deaf patient or have been involved in a brain deaf evaluation? Oh, most of you?
Probably.
All of you?
So we wanted
I should
to
say all of us. Okay.
We wanted to ask how many are using the World Brain Deaf Project guidelines that we're going to kind of talk about today? How many are using that?
There is a conflict of interest there.
Okay.
Nobody. Have you read it? Do you know that there is this consensus on brain deaf? You're saying yes from Spain? Okay. Are you using it? Are you reading it? Microphone, sorry.
I did read it, but we use sort of the usual practice. We have the protocol in the hospital, which is adapted based on the evidence we've got.
Yeah, the problem we will discuss also today. With Cherry, we already discussed that there are a lot of difference between countries, and probably we will not be able to address all of them today, but we want to return back to the basic and to define.
So there are Canadian guidelines, U.S. guidelines that are based on the World Brain Death Project, but let's just go into the case. Yeah?
Yeah, please.
All right, so we have a 63-year-old woman who's found down. She's intubated in the field. She's got a subarachnoid hemorrhage, you see on scan, and a right MCA aneurysm. Her Hunt and Hess is 4. She's withdrawing to pain on the right arm and leg in the field, so GCS is 6T at that time. But by the time she gets to the ICU, or actually into the emergency department, she's got 4T. The neurosurgeon sees her, places an EVD. It's under pressure. They take the patient to endovascular coiling. She comes back to the ICU on fentanyl and midazolam infusion. So there's a temperature, 35 degrees Celsius. Blood pressure is 170/80, MAP of 110. And her ICP is 100, and you try and treat that with your hyperventilation osmotic agents. Her exam's terrible, so GCS is 3T, no cranial nerve findings, no blink to thread, her pupils are unreactive and large. She has no oculocephalic or ice water caloric response, no cough to suction, no gag response, and no response to pain. So, is this patient dead? How do you folks say? So why can you not say it yet?
I was taught as a junior, you're not dead until you're warm and dead. She's a bit cold. You've got some drugs on board which are confounders as well.
Very good. What temperature do you need?
I've been taught 36.
Everybody agree? So the World Brain, the guidelines in the project is 36 now. So it used to be... Okay, very good. They're just saying that it's cooler in the UK, 34 degrees, but that probably will change. So, and sedation, how long do you wait for sedation to wear off?
Is a short-term sedation now.
Depend on the sedation, or depend on their clearance. I would worry on this patient about pronouncing her dead.
Where are you from? UK.
Yeah, so currently the guidelines are saying you want to wait at least 5 half-lives. And if you have liver or renal failure, you really need to wait at least that long. The current guidelines do have sort of a time frame of, but these are short-acting. And so, but you definitely want to make sure that patient is warm and dead and no sedation. What about blood pressure? Does anyone know what the guidelines are for blood pressure requirements now? So typically MAP now is greater than 75, or for the kids, the 5th percentile for age. So we're using, instead of before it was systolic greater than 100, it's now higher. What does the ICP tell you folks? What does that make you worry about that high?
Any answer about the ICP?
Patient's probably coning.
It's probably coning. Yeah, maybe. Do you see the pupils? Both of them are reactive.
Reactive.
So what's the patient's cerebral perfusion pressure, if you do that equation, what is the cerebral perfusion pressure? So remember, CPP equals MAP minus the ICP. It's nothing. It's 5. So
Yeah,
that's
it's
within
very,
range of
it's
error.
marginal. It's very low.
Right.
But do you need all of this information for declaring the patient brain death, Shirley? Do you need to have the ICP or all this information?
You don't need the ICP, but I do have to say that the current guidelines are actually trying to get you to image the patient too, so you actually can go to the family and you have an actual reason because you think she's coiled, she's been treated. The first image didn't show any reason why she should look brain dead, right? So clinically, it looks like she is. So you really should be getting an image. So this is the image. You can see that things look, that she's got the intraventricular hemorrhage, gray-white's looking bad, and the cerebellum, again, gray-white ratio is terrible. You see the aneurysm, subarachnoid blood. So certainly this scan is consistent with someone progressing, so that's helpful. Okay, so I just put this up there, and you guys can go through. We're not going to, this isn't the lecture, but these are all there now in the guidelines of the sedation wearing off, barbs, that you don't have drug levels that are high. You have all these electrolyte things that are in the guidelines as well. And we talked about the mean arterial pressure. So what about this now? We rewarmed the patient, not cold anymore. We waited 5 half-lives. Now the patient's family comes to the bedside and said, hey, she was found at the bottom of the stairs when we called for the emergency team to come and get her. And so we don't know if she had trauma as well. The exam's still unchanged. Can you declare this patient? What do you worry about now?
Let's give her a microphone.
Here in the backside, we were saying there was concomitant trauma that needs to be excluded.
Absolutely. Very good idea.
What specific
Exam, what specific
trauma?
exam, what are you thinking about? Spine?
Right. So what about her presentation? She was withdrawing when she first got there. Does that help you at all? I should give this back to you.
Yes, I cannot remember the slide actually, but she was withdrawing. Drawing, but was it symmetrical?
One side.
On side. So that would give you some inclination about peripheral nerve damage or central nerve damage coming from the spine. So that at least at one side she has intact cervical spines.
So you do worry about the spine even though they're moving on one side, but it is reasonable to look for imaging for a CT. Dr. Sotero, would you agree?
No, I was asking her what kind of images would you like to order now?
Yeah, it depends on what kind of hospital you're in. And in the Netherlands, you don't get an MRI in the weekend unless there's very, how do you call it, urgent reason. So MRI would be best. And if you don't have a CT scan of the cervical and thoracic spine.
Okay. Even if the patient has 100 of ICP and...
Yeah, we only do ICP in neurosurgical centers in my country.
Okay, so in your center you're not using it?
No.
Okay.
So, okay, so C5-6 fracture, grade 1 anteriolisthesis, no intrusion into the canal. So you still know that the patient was moving. If you were worried that they may still have spinal cord injury, what testing does your hospital, or what would you do at that point? Say the exam looks like fine. Would you do the apnea test now? Could you do the apnea test now?
Rafa, what is your opinion?
Sorry.
No, I like your conflict of interest.
So, but I would like to remark, link it with the previous talk. So when this patient arrives to your ICU, then you are thinking of withdrawal or life-sustaining therapies at this point because you are moving to declare brain death. You're not trying to treat the patients. So at this stage, right or not? So when the patient arrives,
we didn't
the patient
define
arrives,
yet.
You have seen all of the patients, and you said, okay, it's a catastrophic or devastating brain injury. Then let's move to diagnosis the brain death. You are doing something like, because you are rewarming the patients, because you are not treating the refractory intracranial pressure, so you are moving to declare brain death, right or not?
Yeah, I think so, but I think also
Okay.
timing
No,
is
I think
important.
it's okay. I think it's okay.
Timing is important.
Timing is important.
How long do you wait for starting all the procedure?
Okay. So at this point, for me, it's fantastic approach. So okay, it's a devastating brain injury. There's nothing to do. So let's move to try to diagnose this brain death. Okay, let's to follow step by step. First, the confunders to try to the prerequisites.
And we decide to wait for the drugs.
Yeah, to wait for
Okay.
the drugs, of course. So
we increase the temperature of the patient.
increase
We
the
put
temperature of the patient. Right,
went
try
to 36.
Okay, 26. No, 36.
36.
36?
36.
So yeah, 36. So I think it's like to follow step by step the prerequisites, not confunders, the perform of the whole clinical exams, and to try to, if you need an ancillary test or not, including in the whole exam the apnea test, obviously. But I'm not sure with the data at this point. We are ready to perform the apnea test. I needed to know more about the confunders or the prerequisites. If of the exam it's okay, let's move to the whole clinical exams.
If we make the assumption that all the confounders are fine, the question I have for you is, can you then move forward to apnea test?
It's for me or for
everyone.
the clinical exams? At the clinical exam,
Did you know? Did we know?
Intracranial pressure changed.
Intracranial pressures, if anything, 105, equal to the MAP.
You have a question?
It's just that you've put that up, but has she had do we know that she's not got a cord injury? Because if she's got a cord injury...
So that's a good question. So that's exactly right. So if you thought that for sure she had, a cord injury, then to the point of looking at an MRI, then you would not do an apnea test. But if you had the suspicion she was moving before, this is a minimal finding, right? So basically it would not preclude the apnea test per se. But the reason why I bring this kind of difficult case up is because I'm curious what you folks all think, because one of the things that they found, and part of the reason why we need to standardize it, people would go straight to an ancillary test without doing an apnea test in some patients and thinking they didn't need to do a clinical examination, but that is incorrect, that we need to do the examination as much as we can, all the elements before we move to another test. I think in this, you might consider doing an ancillary test, because what are you going to lose? What part of the exam will you lose by having a cervical spine injury? We can see the cranial nerves. What can't we see? Arms and legs. And the apnea test like you talked about. We wouldn't be able to do it. So for sure it was a spinal cord injury. Definitely we would not do an apnea test. We'd move to an ancillary test. How many folks have this? So the new guidelines are saying the ancillary tests, at least in the U.S., are to do cerebroangiogram or a nuclear blood flow study or transcranial Dopplers. No longer EEG, and they're recommending no CTA and MRA. So how many of you in your hospitals have the availability of nuclear, start with that, nuclear blood flow in your hospitals? No? Okay. How about for cerebroangiogram, four-vessel angiogram? A few. Okay. Transcranial Doppler. Okay. So we have some...
But also we have some, let's say, legal and national guidelines on this setting, because every nation, I was thinking of my country, have its own laws on the determination of blood flow. And so in our country, angiography, nuclear medicine, TCD, and angio-CT are allowed.
CT angio, they're allowing that.
Yeah,
Okay,
absolutely.
Very good. Interesting. I think that the U.S. guidelines, and I think Canadian, and Vicki can say, but I think that they said no for CT angio because the data are still questionable.
I was just trying to remember because Michel Chassé, who's doing a trial called Index CTAP, who's been looking at CTA perfusion and validating that, but I don't think Michel has completely published that data, but we were looking at CTA perfusion studies in Canada, but you're right, like it's not quite there yet.
Who is going to use CT perfusion or angio-CT for the diagnosis? UK? Switzerland? Italy?
In Norway, actually, we are obliged to do, of course, we do clinical testing and apnea test first, and then we have to confirm no cerebral perfusion by
For all the patients?
all the brain-dead patients.
And so,
That's required in Norway.
and which test are you using for confirming?
A CT angiography.
So you do CT angiography to all the patients that will be diagnosed brain death afterwards?
Everyone for brain death diagnosis, yes.
Okay.
It's a specific Norwegian phenomenon.
So in the UK, it's, as of last year, the guidance is to do a CTA using the Frampus guidance, looking for absence of flow intracranially. And in the new diagnosis of death using neurological criteria, which is coming out later this year, that will be made more hard-hitting, that incorporating what we call our red flags will pretty much necessitate the use of CT angiography.
Rafa, do you use angio-CT in your setting?
I would like to remember that it's not mandatory to add an ancillary test.
No, in this case in which we can have some doubt, maybe we cannot go to the...
Say
we are not sure about the spinal cord injury till now, because we don't have a MRI today, and probably it's not a problem. But if you need to go in to having another exam, what are you going to do? TCD, angio-CT, whatever you're doing. CT perfusion?
We usually use CT perfusion or angio-CT, or if you want, you can use wherever you want. You can use wherever you want. It depends on your availability of center. But for example, for a Spanish framework, you can use wherever you want, even EEG. So that's so terrible. So.
How many hospitals are still using EEG? That was my next question. Yeah, so interesting.
In my country, it's still, in Germany and in Italy, it's still mandatory.
To do an EEG.
Yeah, it's mandatory by law. So you need to do the apnea test, and VEG is required for the diagnosis. So you cannot skip it.
Very interesting. So every country is different, which is part of the key is knowing what your country, your region that you're in, because in the U.S., different states are different, and what your hospital is requiring as well. So that's very important. Okay. So we did that.
I would like to add, Cheryl, but I think that we find some difference, but we already discussed it. I think some principles remain in all the countries, and the legislation could ask, for example, of having an EEG in my country, in Spain, or in other country. But at the end, the apnea test is something that is done everywhere. And I think also the reflexes in every law, there are different nuances between the list of reflexes to be tested. But at the end, the apnea test is the only test that everyone is going to perform in this setting. Then there are differences all around.
Right, very good. So some of the things and requirements, and we talked about if there's a risk for injury, you need to get films. We have these prerequisites of pre-oxygenating the patient. One of the new things about guidelines is making sure that the baseline PaCO2, and again, this may be different for different countries, is at 35 to 45, but also that the pH is changed as well. Let's see if it's here. So these are the guidelines here where when you're doing the apnea test, if your PCO2 is greater than 60, 20 over the baseline if it's a chronic CO2 retainer, and that's different too. In our hospital, if you're a chronic CO2 retainer, it is required to do an ancillary test. And then the pH is a new requirement as well, 7.3. Again, different for every hospital, different countries, but just so you're aware. And then if you have a patient on ECMO, there are different things that you do as well. So we're going to pre-oxygenate those patients. We're going to reduce the sweep gas flow in order to let that CO2 rise. But also for the ABG, if it's a VV ECMO, you need to have both the MAP and systolic. This is for the U.S. be that greater than 100, or sorry, greater than 75. But if you're VA ECMO, obviously it's just MAP alone that you need to maintain. But depending on where you're cannulated, they want you to also get something post-oxygenation where you draw it. So a little bit different for those. And again, reasonable to look at the guidelines to see. And didn't want to do this as a lecture, but just wanted you to be aware of this. We talked about our ancillary test, but I want to go on to, actually the next question I had, I guess was, I was going to, that slide got taken away. So the family, sorry, I know where it is.
Cheryl, why you are not using angio-CT? Because almost all European centers are using it, and you say it's not suggested. So I would like to go in deep detail now.
Yeah. The guidelines are based on the evidence, and we saw this morning that you have to be aware that evidence is different. But the feeling is when they went through all the evidence that's there, there's still questions. There are times where you have false positive CTAs. So the feeling was, and MRAs. So the feeling was that not enough evidence at this point. I can only tell you what the studies are. So I'm going to, the pieces that didn't come up here, and I apologize at the animation. So say the family comes in and they says, and you want to do the apnea test, and we passed by that. And the family says, no, we don't want you to do an apnea test. How many of you have run into that, where the family says, we don't want to do it? Now, what do you do?
Where are you from, UK?
UK. What do you do?
We have had a family that have refused a test, and there was some discussion whether they can actually refuse a test. I think in this case, it was the patient was dying, so that's what I think they didn't do the test, but the patient died.
So are you required to ask permission to do a test like this? Like, do you ask permission to do a chest X-ray if you're trying to diagnose pneumonia?
No.
So the guidelines are saying you should not necessarily ask permission. You basically tell the family, this is part of our examination. We need to know what's going on with the patient.
I think in this case, the family sort of anticipated it and said they didn't want it done because they knew it was coming.
And what if the patient didn't do it? What would you have done?
I think we would have still done the test. From a legal point of view.
I think following also the Rafa reasoning before, if we do step by step what we are looking for, I think we arrive to apnea test very naturally because we have a patient with a devastating brain injury coming in the unit. We try to save it, closing the aneurysm, putting an EVD and so on. And then the information we are giving to the family over time is that the patient is going to have a deterioration over time. When you have 100 millimeters of mercury ICP, you can say that there is no perfusion of the brain, and everyone could understand that the perfusion is minimal. So I think I discussed with family for many years. We arrived to the diagnosis after different steps in which in our mind we clear the confounders, we check everything before starting to talk to the family. But the family arrives to the diagnosis with a path with you because you say, I'm trying to save a patient, I'm losing control of the situation is very severe and there is no perfusion of the brain. And the question usually comes from the family, what's next? Because the family usually asks what's next, and you introduce the path we are describing. And with Sherry Lee, when we discussed by email this talk, she said to me, and what about the family that refuse? And I said to her, there are a lot of different countries because we try to discuss with the family that is a legal requirement. We cannot stop it. And if we are not able to do it now, we can wait 12 hours, 24 hours, but then we will do it because it's mandatory. And we remain inside the law in our country because it's mandatory for futility to stop treating a dead patient, and we need to declare the patient dead. So there is no alternative.
So if I were the family and said, I have a loved one who's coming to the bedside, do you have a time frame that you can leave a body on a machine, a brain dead, someone is brain dead? And actually some of the terminology I start using to help the family understand, one is, I'd like to ask, let's step back for a second, how many actually have the family at the bedside while you're doing the exam so they can see everything you're seeing? Because I think that's a really helpful thing to do. I like to show them the scan, if you've got one, to explain to them how severe the injury is, and walk them through what you're looking for when you're looking at pupils, corneals, everything, so that you can tell them what's normal. And then I think that's an important point. But the question I have is that at that point, depending on your country or your state, how long you can leave a body on that machine at that point. Do you have a requirement? Like
There is no
6 hours,
legal
4 hours?
requirement, but as short as possible.
Yes.
So I need to discuss with the family. If I have a fight with the family, I can wait 12 hours one day, but the day after I will do it. And usually we try to do it on the same day because the story we are building with the family is a clear story. At the end, the family understand before we are telling them we are doing an apnea test that the patient is dead, because we are preparing the family over time. And usually we don't have any problem in discussing with them the timing of the exam, at least in my country. And when there is any legal problem, we say we are obliged by the law to do it. It's not my request, it's the law in my country that requires to do it.
And that's exactly what we use too, is that legally we can't keep a dead body on a machine. And I think that helps the family to finally understand that. I
think we have 3 minutes, and we can leave the question from the floor. If there is any question, we can discuss together. Any question from the floor? No.
Sorry, I actually move away from the ethical question. I had a very practical question about the apnea test. I think in the guidelines there is no specific test that is recommended, but in your slide I could imagine that you recommend the insufflation with a catheter. Is that right? Or because I worked in different hospitals and everyone makes it different. Yeah.
There is a small risk in the way doing the apnea test this way, like the Americans suggested in the past, because it could produce a pneumothorax sometimes. We are usually use a bag with a 5 centimeter PEEP with an oxygen flowing inside, and the entire CO2 recorded that is remains zero. And sometimes you can make a small insufflator look at the CO2 at the stage, and then we do an ABG when we suspect that the CO2 is enough. In Italy, 60 millimeters of mercury plus 20 since the starting point. But we are not using the insufflation with a catheter. We're using a balloon with a PEEP because I think we need to keep the PEEP because the patient could be a lung donor. So in our setting, we are doing that way. But everyone is doing, if you read the literature, differently.
There are differences that, like you saw, the intratracheal catheter, but others are using, like our hospital uses actually the high flow adapter, so nothing's going inside and just keeps a flow by on there, but a small amount, so you're not actually ventilating the patient. So everybody does it a little bit different. And some think about using a CPAP machine, but the problem is our machines are so sensitive now that they trigger even with water in the tubing. So you have to be really careful with that. But there are different ways to do it.
If you keep connected to the ventilator, the problem of auto-triggering due to the heartbeat is usually something that happens. And usually the resident don't understand what is going on. And so if you disconnect the patient for a while and connect to a system, an external system, ambu bag or whatever you want with oxygen, you can see immediately that the patient is not able to have enough ventilation. It's only the heartbeat moving a little bit of air.
Other questions?
Please.
Is there not a percentage of patients that will still have some flow on CT angio that could still be brainstem dead?
So the reason why they aren't using CT angio, at least in the U.S., is because of that reason. But if there's flow, you cannot declare. You have to wait and do a different study or wait and do the study again. So there is a chance that it could be a false negative as well, too. So this is the problem that they've found with that particular study, both MRA and CTA. So this is why it doesn't enter in the guidelines for us.
We are a little bit practical when we go there. We do the TCD bedside, and when the TCD suggested us that the patient is brain deaf, because you need to have a certification for doing it, and nobody defined in Italy who is going to be certificate for declare brain deaf with a TCD. We do the angio at that time, and we don't do angio CT without any information that the flow is going down, and at some point became a flow, a reverberant flow with a TCD. And so if we need to do the angio CT, we do the angio CT at that time. And so we are sure to have an exam with something written by a specialist that there is no flow. So we reduce the false positive problem we had in the past.
So the interesting thing is the the TCD by itself in the US is enough. You don't need to go on.
Also in Italy, but you need to certify it.
So using the Frampus guidance, it overcalls flow in about 15% of patients who are actually dead, but there is remnants of flow. So yes, we potentially lose 15% of patients who could become an organ donor if you don't wait, if you actually proceed down the end-of-life sustaining therapy route. It will be.
I saw in the last slide you put not to use EEG and evoke potential. Like not like
Not to use the evoked potential like a...
avoid it.
Okay.
Why so taxative? Why?
These are the U.S. guidelines, so based on the feeling is the EEG, especially if you have brainstem, patients with brainstem injury, and you see this with somebody with rhomboencephalitis or a cerebellar lesion that crushes the brainstem. They may lose all their brainstem reflexes and still have some activity, but also the EEG doesn't look, the reason why they say not to use EEG, it doesn't see deep signals. So and then the evoked potentials have never been really useful for, it's very surface, so that by itself has never had good data to support that for brain death, not for bad neurologic prognosis, but for brain death. So did that answer your question? Yeah. Okay, very good. I think we're over time. All right. Well, we thank you all for participating. Hope you learned something today. We did as well. So thank you.